Prominent upper lobe vessels on a chest X-ray, a phenomenon clinically termed cephalization or redistribution, is the hallmark radiographic sign of pulmonary venous hypertension. In a healthy upright individual, gravity causes blood to flow predominantly to the lung bases. Consequently, lower lobe vessels are normally significantly larger and more numerous than the non-dependent upper lobe vessels. When you see prominent dilated upper lobe vasculature exceeding the caliber of the lower lobe vessels at equidistant points from the hilum, it signals an upward shift in pulmonary perfusion. The classic pathophysiology follows a strict hemodynamic chain reaction. 1. Elevated left-sided filling pressures. Whether due to left ventricular systolic or diastolic dysfunction, mitral valve disease or volume overload, elevated left atrial pressure backs up directly into the valveless pulmonary veins. 2. Dependent interstitial edema. Because hydrostatic pressure is naturally highest at the lung bases due to gravity, fluid first leaks into the basal interstitium when pulmonary capillary wedge pressure rises. 3. Reflex vasoconstriction. This perivascular interstitial edema compresses the basal pulmonary vessels and triggers localized hypoxic hypercapnic vasoconstriction in the lower lobes. 4. Flow distribution. With vascular resistance spiking at the bases, pulmonary arterial flow takes the path of least resistance, diverting upward to the normally underperfused, highly compliant upper lobes. Cephalization acts as an indirect visual manometer for estimating pulmonary capillary wedge pressure in acute or worsening decompensation. Pulmonary capillary wedge pressure range 8 to 12 millimeters of mercury is a normal baseline. Basal vessel caliber is more than that of upper lobe caliber. 13 to 18 millimeters of mercury, cephalization, equalization or upper lobe dilatation. Pulmonary venous hypertension stage 1. PCWP 18 to 25 millimeters of mercury. Radiographically you see interstitial pulmonary edema manifest as curly B lines, peribronchial cuffing, hazy hyla. When the pressure ranges above 25 millimeters of mercury, it causes alveolar edema, the classic bat wing or diffuse alveolar apicities. Here is an illustration of curly B lines on a magnified spot film. Typical bat wing pulmonary edema on chest X-ray with a bat wing for comparison. There are certain critical clinical caveats. Before using cephalization to drive clinical decisions, 3 major confounding variables must be ruled out. The supine trap. Cephalization can only be reliably diagnosed on an erect PA or a P film. When a patient is supine, such as in portable ICU chest films, the hydrostatic gravitational pressure gradient between the apex and base is eliminated. Perfusion naturally equalizes, creating pseudo-cephalization. Basal destruction, shunting of flow. Severe basal emphysema or extensive lower lobe fibrosis mechanically destroys basal vascular beds. This forces blood to the upper lobes regardless of left heart pressures, mimicking cardiac redistribution. High output and shunt states. Left to right intracardiac shunts like AST or VST, or systemic hyperdynamic states like thyrotoxicosis, severe anemia, AV fistulas cause generalized pulmonary hyperperfusion. While upper lobe vessels enlarge, basal vessels usually dilate proportionally.